Hello, today's lecture is over chapter 10, and all right, there we go. We are focused on Medicare, medical care. So this is physical and mental illness. All right, so the first question is, what is going to be social about health and illness, right? You might be familiar with these topics from more of a biological perspective, but they are not only determined by biology. What it means to be sick differs from one culture to another, and diseases are also interpreted differently across cultures. So, some aspects that can change, right, across cultures and groups that are going to affect different diseases. And this is just a very beginning introduction, not an exhaustive list. But different religions, racial, ethnic groups, or even the type of society that someone lives in. So the US is an individualistic society, but there are collectivist societies that are more focused on family, right, and group belonging that way. So you can think of like some Asian countries. So depending on these different variables, it's going to influence how depression is viewed and managed and treated, or if it's just something that's dealt with, right, by the individual or the family. How schizophrenia is viewed, if seeing a therapist is socially accepted or something that is something maybe to be ashamed of. So there's lots of different aspects of health and illness that have that are influenced by social variables, and so that's what we're going to really be focused on. So thinking about this as a social problem, and some social causes of illness and disease. So, industrialization, I've talked several times about how the United States switched from more of an agricultural society to an industrialized society. That changed lifestyle and that had an effect on people's health. So, as people went to work in factories or office work, we saw that heart disease started to become the top cause of death, the leading cause of death. And a big explanation for this is that there was a change in lifestyle. So the going from farming societies to more industrialized work, it led to higher incomes. People could have more savings, right? They were making more money. So this led to a change in lifestyle. So they could spend money on and afford richer foods. And by richer foods, I mean like foods that are more rich in things like fat. And then also people saw less exercise, right? And we know farming work is much more physically demanding than office work. So this led to a change in lifestyle, and these lifestyle changes contributed to the rise of chronic diseases. So heart disease is one of those. So lifestyle that we have today involves several things. So first off, the pursuit of pleasure is more of a cause of disease. And so this could be pleasure in terms of food that we're eating and we want to enjoy, even though it might not be that healthy. Maybe less exercise and more relaxation, even sexual pleasure. That goes into the second point there, that STIs. We have an increase of some STIs, right? It kind of depends on what you're focused on. But anyways, those are resulting from unprotected sex. So sexual pleasure that's being pursued, and then also diseases that arise from smoking, drinking, and then doing certain drugs. So all of these being social causes of illness and disease tied to lifestyle. And then there's also something called iatrogenesis. And this is induced inadvertently, but it refers to medical errors or medical treatment that harm patients. And so this can happen in several ways. So patients sometimes take multiple drugs that might experience, because they're taking multiple drugs, right, and they're getting one drug from one special medical specialist and one from another, there might be dangerous drug interactions. Especially if a doctor or pharmacist doesn't know everything about the drugs or all the drugs that the patient is taking. They might prescribe them one and then the patient takes it and it's harmful for them because it interacts negatively with another drug they're taking. Also, patients that get treatment in hospitals, they might pick up an antibiotic-resistant staph infection, which is also harmful for their health, even though they're going to the hospital to get treated. So that's an example of iatrogenesis. I guess lately, maybe patients who went to the hospital during COVID that didn't have COVID, right? They went for another reason. They might have contracted COVID because they were in a hospital, right, where there were some COVID patients. And then also surgery, when surgery is done, the wrong part of the body or the wrong leg or arm or foot is amputated, that would definitely be an example of medical error that's harming patients. 2016 data shows that about 400,000 Americans die from iatrogenesis each year. So that's something, a significant amount of people, right? That's something to be concerned about. And obviously social causes here. Okay, so jumping into healthcare in the US. I don't know, that thing just came up all by itself. I don't know why. Okay, it's gonna stay. What do you know about the system of healthcare in the US? What I was getting at here is expenses, right? And what is covered and what isn't, even if you are really sick. So even with insurance, health insurance, having a serious illness in the United States and needing to get treatment for it can still mean financial distress, right? Even though you have insurance. And so this is results from, let's see, I'm trying to get I guess I don't have the date here, but essentially there were telephone interviews with about 1,500 Americans who either had a serious illness or they were caring for someone who did, right? So they had some knowledge about serious illnesses, and the results are nationally representative. So it's good data. But essentially, they asked people, have you used up all or most of your savings to pay for your medical treatment? People who weren't insured, a higher percentage of them said that had happened, but still 36% of people who had insurance still had to use their savings to cover it on top of insurance. Being contacted by a collection agency to pay bills, unable to pay for basic necessities. I mean, these are a huge percentage of numbers of people that aren't insured, right? Having some of these hardships. Borrowing money or getting a loan, being unable to buy health insurance because of having a pre-existing condition. This has changed under Obamacare, but if you aren't getting insurance through the marketplace, right, you have some kind of private insurer, this is still possible, right? You can not get coverage because of a pre-existing condition, like if it's a private insurance company, and then having to declare bankruptcy, these numbers are the same. So the medical burden of healthcare costs in this country is high and is a problem. And if you know anything about how the US compares to, if you know anything about the healthcare in other countries, right? You know, some places have what's been called socialized medicine. So like Great Britain and Canada, right? You're going to get treated for a condition no matter what, because it's not covered through this insurance system like we have here. Okay, so medical costs in the US have not always been outrageous. It has happened kind of a boom, and you can see this steep incline over time. So from 1960 all the way to 2020. And so these are costs per year in billions of dollars of healthcare overall, what the healthcare industry costs us. And so we're talking $28 billion, moving all up to, this would be what, trillion, right? 4.3 of medical costs just being really, really expensive for people to afford, and the healthcare system in the US to need to be getting money from, right? Asking people to pay their bills, et cetera, paying their workers. So why? Why have medical bills grown in the US? Three main reasons. The first we talked about at the beginning with the aging population. So we've got more older adults in our population. This is partly happening because people are living longer, right? So we're spending longer in old age. We're spending not just 10 years in retirement, but 30 years in retirement, some people. And generally, as we get older, people need more medical treatment. So that's driving up costs. New medical technology is expensive, right? So there's amazing medical innovations. You can think about like robotic surgery, drug development, vaccine development, but these things are all expensive. And so costs to cover those expenses have driven up medical bills. And then medical care is a commodity to be sold for profit. So in the US, right, you can purchase medical care. You can choose to go to a different doctor, right? If you don't like the opinion of one doctor, you can kind of keep shopping around until maybe you find the answer that you're sort of looking for. But because medical care is a commodity to be sold to profit, that also means that people can set prices, right, that are going to follow along those demands. So the system of healthcare in the US is two tiers. So the system that we have, right, medicine for profit, people making a profit off of this, it's called a fee-for-service medical system. And so within this two-tier fee-for-service medical system, you have people who can afford good insurance and are going to get medical care that follows that. And then you have medical care for people that cannot afford good insurance and the quality of medical care that will follow that. So the US medical care available here ranges from the finest in the world at major research universities and clinics. You can think about the Mayo Clinic and the Cleveland Clinic. I know in the Cleveland Clinic, there's a special wing where for like VIP patients, and we're talking like princes from countries in the Middle East coming to get treatment, right? At places like this, really top tier in the world. It ranges from that all the way to an underground network of unlicensed physicians or foreign trained physicians who they were a doctor in the country and then they migrate here and they don't take the test, so they're foreign trained but unlicensed physicians. So really, medical care in the U.S. runs the gamut. So to talk about an example of this medicine for profit system that we have, we can look at C-sections or cesarean deliveries. And what we know over time is that there's been an increase in babies that are born via C-section. And so C-sections aren't necessarily the best option, right? It's not that this increase in C-section is corresponding with women's bodies being unable to give birth vaginally. It's some other social things that are happening. So C-sections bring risks to the mother. There can be bleeding risk or blood clots, sterility, ruptured uteruses, right? And there's also the recovery time that's built in because a C-section is a surgery. So thinking about what the mom might need to do, right, for work or have someone take care of her and the new baby at home, etc. So it does require longer hospital stays for mothers, which drives up costs. The bill goes higher. And most C-sections are medically unnecessary. So then the question is, why? Why has there been an increase in C-sections if we see that there are some risks associated with it? I'm going to go over them on the next slide, but essentially this varies also by the hospital that we're talking about. So some hospitals have higher rates of C-sections than other hospitals, even though they're in the same, there's two hospital systems could be in the same city and serve, similar patients from similar backgrounds. But the doctors in some hospitals promote C-sections while doctors in other hospitals are less likely to promote them. But why are we seeing a rise? So profit is one. There are extra profits from a C-section versus a vaginal birth that motivate many hospital systems to prefer this method of delivering babies. Right, I said it's an extra procedure, women have to stay longer, etc. Convenience. The timing of the birth is scheduled, right? The OBGYN doesn't need to roll out of bed at 3 a.m. because their pager goes off because their patient is going to have a baby. No, they can wake up on Tuesday morning and know at 9 a.m., right, I have a C-section scheduled. And actually more births occur on Tuesday than any other day of the week. And this kind of makes sense, right? No, people don't want to have to go to work on Monday and have a hard day ahead of them. You've got like that in-between day to transition from the weekend to the work week. Tuesday's the day. Technology. So there's a lot that goes into this, but essentially there are alarms put on mom and fetus, especially when the mom is in the hospital, right? So there are fetal monitors that can go off, but it can go off for any number of reasons. It's just this alarm, right, that's going to go off. So if it goes off, right, it might be indicative that we need to get the baby out now, right? But we can't really be sure. And so it's just a way to, well, just to be safe, right? Even if it was something like, yeah, the baby's heart rate went up because, I don't know, they were having a dream or something. The response is going to be, we need to get the baby out now, just in case the monitor is going off or whatever. There's no way to be sure of why the fetal monitor went off without harming the baby, so they just do the C-section. Preference. Some women do choose to have a C-section delivery, right? It might be just like the doctor. They don't want to have to worry about it being 3 a.m. They might want to know that they're going to be in the hospital and can anticipate the birth and be more prepared. They might also want to avoid childbirth pain and just go through the C-section. So there's a lot that goes into it, but these are all social aspects, right, of this health topic. And profits that are being derived from C-sections costing more than vaginal births have increased over time as C-sections have gone up. Okay, so the scope of the problem. Thinking about physical illness itself and zooming in on life expectancy, we've seen an increase in the past century. In the US specifically is what I'm focused on here, but also in other countries, more so in developed countries. Um, that, oh, sorry, I thought I was talking about, I thought I was talking about age. Sorry, life expectancy. Okay. In the US, between 2014 and 2015, life expectancy at birth, meaning once a baby is born, how long are they expected to live before they die? Life expectancy at birth in the US actually dropped 0.2 years between 2014 and 2015, which was the first time since 1993 that it fell. And then 15 to 16, again, dropped another 0.1 years. And the biggest contributor to why life expectancy is decreasing in the US during these years was actually the opioid epidemic. People passing away, because a lot of these are people that are younger that are passing away, right, compared to like old age. And it was driving down our life expectancy. So it's about 78.7 years right now. This number, though, how long on average Americans are expected to live, varies depending on certain groups. So socioeconomic status matters, race, ethnicity matters, gender matters. So for SES, those that have higher education and higher income, they live longer than people who have lower of those. Asian Americans generally tend to live the longest, and Native Americans tend to live the shortest. And then women live longer than men. So we'll talk in class about how life expectancy in the US compares to other developed nations. And so this is just focused on countries that have like been industrialized and are now considered in the developed world. Do you think that the US is the same, higher, or lower? We will talk about that. Maybe you'll have a better guess as I go through the rest of the slides and we talk about it in class. Okay, another aspect associated kind of with the scope of this problem of physical illness, we can think about heroic versus preventative medicine. So we live in an age of chronic illness, meaning, so there's chronic disease versus acute disease, which I nicely have here. So an acute illness or condition or disease, well, not really a disease, illness condition, is going to be something that's short-lived. It happens quickly, it's severe, there's sudden onset, but it's a short amount of time. Chronic disease is something that's a disease that's long-lasting, so you have it for a long amount of time. It progresses slowly, and then it's not easily cured. So here's a nice little difference. So there's different types of medicine associated with treating these things, okay? So preventative medicine is going to be medicine that deals with chronic diseases. And it's really focused on day-to-day, what are you doing? Are you eating correctly? Are you moving your body? Are you getting enough sleep? Are you trying to keep your stress low? It's really not a dramatic type of medicine in terms of practicing medicine and managing it. Heroic medicine, on the other hand, fits in more with these acute, severe, sudden onset diseases. Oftentimes the cases are complex, it can be technical, and then treatment can be expensive. So if you have ever seen a medical TV show, they're not raking in viewers and becoming popular because they're depicting preventative medicine. The boring, quote, boring, you go to your family physician and you check in, right, once a year, and they do some maybe blood work, and they're saying, okay, we have to give you this medicine or manage your meds for your diabetes or your cholesterol or your blood pressure. No one wants to watch those TV shows, right? But that is really the bulk of what is happening in the US because we have a lot of chronic diseases. Instead, the TV shows about medicine are heroic, especially the first episodes. It's just so funny to compare them, right? Like there's almost a resident who's about to start their first day. Residents don't know anything their first day. And they're in like a train station and a person falls right in front of them. And they take all their 2 years of medical school classes and they know, oh yes, they have a collapsed lung and they have to borrow a knife from someone's pocket and someone else gives them a straw and they cut open their lung and they cut open along their neck to get in and they stick the straw in and they blow into it to expand their lung. And it's like, no, that doesn't... It's an acute disease, right? Of course, that lung collapsing, but the bulk of medicine, because of how the health in America is actually more focused on you need to take your meds, you need to make sure that you're keeping, right, your blood pressure in check, you need to change your diet, exercise, etc. So the emphasis in US medicine on specialists, right, having specialized doctors and specialized hospital care is fitting more within this response to acute diseases and complex cases. And I'm not saying we don't have this, right? Of course, those doctors are important. It's just that we have a lot more people with chronic disease, and so preventative medicine is more important. But because there's more of an emphasis on this, and it's what's glamorized on TV, it's why people want to go into medicine. We have a shortage of primary doctors, which is going to be difficult. It already is difficult, but it's hard as we have an increase of chronic disease and especially aging patients. They're just treating, routine problems. Okay, that was a lot, sorry. Mental illness. Has mental illness increased? Do you think that we've had an increase of mental illness or mental health problems? The answer actually is that experts, their answer to this question changes, and a lot of them disagree on what mental illness are you talking about? How are we measuring this? So actually, we don't really have a good way to know the answer to this question. Part of this is complicated by there's controversy that exists in determining what a mental illness actually is and if it exists. And you can see this if you look at the DSM. So the DSM stands for the Diagnostic and Statistical Manual of Mental Disorders. It's like the Bible for people in psychology and psychiatry. So it's put out by the American Psychiatric Association, and they're on version 5. I think. Hopefully there's not a 6. It doesn't matter how many there are, because I just want to show you how it's changed over time, right? So this is getting into the social understandings, explanations of mental illness. DSM-1, the first one came out in 1952. There were 106 diagnoses. The book itself was 130 pages. Fast forward to DSM, I guess I only have 4 on here, sorry. 1994, even the one that was the text revision, so there was some revisions in it, so let's go to 2000. 365 diagnoses, 943 pages. So the question is, between 1952 and 2000, did we just develop all of these 200 plus new types of mental disorders, or are we starting to classify certain things now as a mental disorder versus before it wouldn't have been? I err on the social answer to that question. Okay, theory. Starting with symbolic interactionism. So reminder, symbolic interaction is focused on how people determine meaning and then how those meanings influence their behavior. So there's different ways that this applies to health, especially health, illness, and then the practice of medicine. So we can look at, and I'm going to go through these, the meaning of symptoms, the significance of definitions, medical definitions, health definitions, conflicting referral networks, and then depersonalization within the healthcare system. So first off, the meaning of symptoms. We use definitions or labels that our culture provides, especially when we're thinking about what does it mean to be healthy or not healthy. So people from different backgrounds can interpret their experiences differently. So for example, for back pain, right? Some people might experience, let's say we're just talking about people in 2 different types of labor. We have someone who's doing more manual labor that's physically demanding, and someone who is doing, their job is mostly sitting at a computer. The person that is doing manual labor might experience back pain, and it's something that they've been used to, and it's just something that they deal with, and they are not going to seek any care for it. The person at the office might not be used to experiencing back pain, and one day they do, and it's like, I have to go get this checked out right away. So the meaning of that is going to change based on the group. And the same goes with cold symptoms. Some people might put up with symptoms of a cold and just kind of try and go through it and keep their head down until, it goes away. Some people might be like, nope, I cannot do anything today, right? They totally crumble if they have any kind of symptoms of a cold and they have to go to the doctor and get it checked out. It's going to depend on how they were raised, the culture that they come from, the job that they work in, the gender, right? The age. There's lots of different variables that go into the meaning of symptoms, but the meaning itself is important for the course of action that follows. Okay, also we've got significance of definitions. So the labels or definitions that we apply to health, they become lenses through which we view the world. So I'm going to go through some examples. So drunkenness versus alcoholism. Drunkenness is something, like if we use the word drunkenness, which, okay, let's go back to, I don't know, give me like 50 years prior. Drunkenness is something that is connotated with either being sinful or being morally weak, right? You're a drunk. Alcoholism, on the other hand, if that term is used to describe the same thing, it's a disease, right? It's a condition, it's a disease, you need to get treatment for it, you're sick, you need treatment, right? You're an alcoholic versus you're a drunk. So That's one definition or one example of these difference of labels, and then kind of how we view the problem or the person that has the problem and how they also can or cannot get treatment. Opioid use disorder is another one. So actually, opioid use disorder was added to the DSM-4 TR, that one that was in the 2000s. And it's now characterized as a medical condition where the person has a problematic pattern of opioid use that causes clinically significant impairment or distress. And so before it was just, somebody doing drugs, and now it's someone with opioid use disorder, right? So that's another example. The APA, American Psychological Association, they used to list homosexuality as a mental illness that could be treated. So it actually used to be in the DSM and then it was removed. And when homosexuality is considered a mental illness that can be treated, this has recourse, right, for the medical system. So if you've heard of conversion therapy, this is sometimes psychiatrists, either through like talking or sometimes through drugs that were really harmful for people's sexual reproductive systems, would attempt to change a person's sexual orientation, right? Conversion therapy. And this is not something that's gone, right? This happens in some places still. So gay and lesbian communities lobbied against being defined as mentally ill. And then thankfully in 1973, the APA dropped this as an illness. So not only are things added to the DSM and considered mental illnesses, but things change so that things can be recategorized as not, right, taken away. Okay, another aspect of symbolic interactionism is conflicting referral networks. Patients and doctors use different frames of reference. So let's say me and you were in the patients, right? And then we've got doctors. So you and I are in the lay referral network, right? We are not doctors. And so we are getting our medical information from our family, friends, neighbors, coworkers, people with who we talk about our medical problems, right? So maybe, I don't know, I'm experiencing, well, with COVID, it's a good example, right? People, especially when we weren't sure about like some of the symptoms, right? Like let's say I'm experiencing a loss of taste or smell. And I know that my friend's daughter also had the same problems when she had COVID. So I might say, well, what did your daughter do, right, to help her try and regain her taste and smell? And she's gonna be like, oh, well, she had to use essential oil therapies, to smell things with blindfolded or whatever. But that would be information from not a doctor, right? It would be a lay person, like layman's terms, a lay person, just you and I, normal everyday people, right, trying to get our information from other people. Contrast to the professional referral network. So this is a network of people that are made up of physicians and other medical professionals who have been trained. And these are people who doctors are going to talk to, right? So this now an example, we've got two doctors. Let's say we've got a family doctor and we've got an internal medicine doctor. And so the family doctor, they're out, I don't know, getting coffee. And the family doctor's like, yeah, I've got this patient and they've got this condition with their heart. Like, what do you think I should do in this situation? And so then the internist gives the other doctor advice, right? So, but those are those examples that I gave are two separate types of networks where people are getting information. And so that means that the expectations of patients and the expectations of doctors are going to be different. And sometimes those things don't align, right? And so that can make it difficult for, well, my friend said I should do this when the patient goes in, right? And the doctor's like, there's no medicine, or I'm sorry, there's no evidence to back that up, right? Please stop doing that and do this. And it's like, well, that person had good responses, right? So it can just continue in this conflicting manner. And then I think the last one is depersonalization. So this is when a person is treated as an inanimate object. And again, if you've seen any medical show, you've seen depersonalization exemplified. So depersonalization can happen anywhere, but it's common in the medical setting and for several reasons. So as an example, there are really long waiting periods with like little concern about what those people need to go and do. It's that they have to be there and wait until the medical system's ready. Usually there's little eye contact, and it's more concern for the body part, not the entire patient. So for example, right, like instead of Mike is in room 3 with a heart attack, it would just be heart attack in room 3, right? Like the person is totally removed from the situation. It's just whatever the doctors and nurses and staff have to deal with. So they're depersonalized, right? They're stripped from like their personal identity. Patients who feel that they've been depersonalized as they go through the healthcare system, they actually have a greater tendency to sue doctors. So this then leads to doctors practicing what's called defensive medicine. So in order to kind of cover their butts and not get sued, doctors will order and sometimes run unnecessary tests just to make sure that they covered all their bases, especially if it's a patient who clearly is like asking a lot of questions and wanting things, like even though they don't need complete blood work done, they're going to run it anyways because the patient is asking for it. Unfortunately, this practice of defensive medicine that comes out of this culture where doctors are targets, for lawsuits, it adds money to our nation's medical bill because there's all these unnecessary tests or unnecessary consults done that just cost the system more. Okay, that was symbolic interactionism, those 4 aspects. Functionalism. Functionalists assume that customs or social institutions, medicine's a social institution, that they persist because they fulfill social needs. And so there are different ways to apply this to what we're talking about. The first is fee for service, which I said, so talked about earlier. Fee for service, you pay, did I? Anyway, fee for service means profit. I'm going to talk about both of these. And then health preventions spread globally. So first off, fee for service means profit. Okay, fee for service means you are paying for whatever medical service you're getting. And because we live in this system where healthcare is a commodity, that's what I talked about. People can charge more, right? You might pay a certain amount for, well, you might pay a certain amount for a physical exam in one part of San Francisco, and another part you might pay, I don't know, $30 less. So essentially, it's difficult for hospitals to make money from people who are healthy, right? If we had a really healthy population, the healthcare industry would not be making as much money as it is. Each year, about 35 million patients are admitted to a hospital. So that's about 1 in 9 Americans, and the average stay is 5 days. And the answer to this question, what's the cost of a hospital stay? It really is going to depend on a lot of factors. But the point is, it has increased. How much it costs to stay in a hospital has increased exponentially, particularly compared to inflation. So even if we take inflation into account, right, the cost of the hospital stay by basic numbers versus the per inflation, it's still increased over time, and it doesn't have any sign of slowing down. So this fee-for-service system then means that the more services that a hospital sells and the higher price that they charge for those services, the more that they earn. So there is some benefit, right, for functionalism, right? It's functional, obviously for hospitals because they're making money, but there is some function for patients because patients can shop around, right? So some medical systems that countries have, like socialized medicine, like Great Britain, there's a doctor that you have, and that's the doctor that you go to because that's where you live, right? If you don't like that doctor, you're gonna have to move because that's just how the system is operated. At the same time, your service might be free or really cheap. And you probably won't have to wait as long. But anyways, here in the US, right, you can go to a doctor. Let's say you know that you have a liver problem and you know that there's an amazing liver specialist in Minnesota, you can go there, right? If they will see you and they have time to see you, we don't have any rules that says that you can't because it's a fee-for-service system and you're paying for what you get. Okay, the second aspect of functionalism that focuses on health illness is the health preventions that have been spread globally. So this is definitely a positive outcome. So that the development that has been happening in Western or developed countries for medicine has spread to other countries. And so here I have an example of child mortality rate. So the child mortality rate has declined over time, which is fantastic. And part of that has been some of the like medical care that has been developed, pills, vaccines, even just understanding, right, like cleaning water and nutrition guidelines and things, spreading that from more developed to least developed countries. I need to update this because a perfect example is the development of COVID vaccines. Not to say that there's not inequality with how these things that are lowering health problems. There's obviously problems with how they're distributed unequally, but from the functionalist perspective, right, it's at least being shared globally to kind of spread those health benefits worldwide. Okay, and then conflict theory. Conflict theorists, reminder, they're focused on inequality, right? So they are viewing patterns of illness and healthcare in the US as an outcome of clashes between groups, right? So different health outcomes that we have are happening from clashes between groups. And they see that the US medical system isn't set up to provide health care being its number one goal. Its number one goal is to make a profit. And so they argue that the poor are sicker than others because they've lost the competition for high quality education, good food, proper housing, good jobs, and even medical care. And so we can look at two aspects that I'll focus on: Medicaid and then these colliding interests of doctors and patients. Okay, so Medicaid, usually it's said together with Medicare and Medicaid, but Medicaid is the aspect of that. So it's a federal program. It provides health insurance for people requiring financial assistance. Medicare goes to people that are 65 and older, right? It ends in an E, Medicare for the elderly. But Medicaid, there's no age requirement. So it provides medical coverage for the poor, but it retains the doctor's fee-for-service system, right? So doctors are still making some kind of profit depending on what their fee is to provide care for these patients. Also, not all doctors have to see Medicaid patients. That's not been federally mandated. So because not all doctors see Medicaid patients, there's more demand for the doctors who do. Also, colliding interests of doctors and patients. Marx kind of leading the way for conflict theory. From a Marxist perspective, remember he was all focused on class and the bourgeoisie and the proletariat. So you can look at that kind of in the lens of the healthcare system as doctors and patients forming two classes. The doctors are the people who control medicine, and then the patients are those who receive it. And so conflict theorists can study this in a number of ways, but one is that they argue that because doctors may not explain their procedures or their diagnosis in terms that patients can understand, physicians can try and keep the oppressed class of patients, that is patients, ignorant and then dependent on the medical system, right? So not really understanding what's going on, and so they are then reliant on the doctors. So that's one way conflict theorists, anyways, explain or understand these colliding interests between doctors and patients. Okay, some research findings on topics related to this. First, we've seen, I alluded to this, but we've seen a historical change in health problems that largely came out of lifestyle changes as we became more industrialized and now today more service economy. So the picture on the left, well, they're both showing the 10 leading causes of death in the US. The one on the left is the 10 leading causes of death in the US in 1900, and the one on the right is in 2017. And 2017 really hasn't changed that much. In 2021, although COVID-19 is somewhere on here. But the point of this is to show the types of diseases at the bottom. So in 1900, pneumonia was the number one killer, tuberculosis, diarrhea and enteritis, and then heart disease, strokes, kidney disease, etc. 2017, and for many years in a row, and still today, heart disease is the leading cause of death in the US, and then cancer and accidents. Pneumonia is not something people die from anymore. TB in the United States is not killing people. And diarrhea, right? We have diuretics and we have proper nutrition and access to nutrition in the US. Instead, the leading causes of death today are more from lifestyle choices. And so thinking about things like smoking, the intake of high amounts of sugar, these things weren't as common in the 1900s or available, but they are now. And so they are contributing to these leading causes of diseases. And these are chronic diseases, long-lasting, slow progressing, not easily cured diseases. Okay, social inequalities in physical illness. So in general, the poorer people are, the sicker they are. Poor children are more likely to be undernourished or lack a balanced diet, which can contribute to health problems either then or as they get older. The working class is more likely to be exposed to toxic chemicals either in their workplace or in the neighborhood that they're living in. And these toxic chemical exposures can harm the nervous system, and that's a bad sentence. They're more likely to be exposed to those chemicals compared to their bosses. So then we're thinking about social class differences. So healthcare reform in 2010, the intention was to reduce inequalities in healthcare. So the Affordable Care Act, also called Obamacare, was passed. The law is still being modified, contested, trying to be rewritten, etc. in Congress. It's still really contested. So it did, however, I want to get ahead of myself here. provide health insurance coverage to millions of Americans, which is one reason why it's still so contested in Congress, is there's no good alternative. So we can't just take it away, right? Vote to revoke it, because then we'll have millions of Americans who don't have health insurance, especially in a time when this country is undergoing a health crisis on top of chronic disease with COVID. In terms of mental illness, so this question, obviously I have answers. There's two explanations for it. So why do the poor suffer more mental disorders than people in other social classes? So we see more mental illness among poor individuals compared to not. One explanation is the drift hypothesis, and this is that people with emotional or mental difficulties tend to be less successful in life, and so they kind of drift downward in terms of economic status, because they've got these mental problems. The other is the environmental hypothesis, and that this is because individuals are in a lower social class and the complications that come with that, more stress, right, over financial situations, maybe frustration with where they're living or the job that they're working, etc. So essentially, people in those classes might be more sad, anxious, stressed, fearful, because they live in these stress-filled lives that have high rates of divorce, alcoholism, violence, and then worse physical health and less access to good medical care compared to people in higher social classes. So that might contribute to the higher rates of mental illness for these individuals. So for this group, sociologists see social class then as producing mental health and mental health illness within this hypothesis. So thinking about social class differences in mental health care, there are five types of therapy, and we can see social class differences amongst them. So individual psychotherapy. This is one-on-one. So a therapist is listening to one individual, what they're going through, trying to guide them towards a resolution of their problems. It's expensive because it's one-on-one therapy, right? So not everyone can afford individual therapy. There's short-term directive therapy. So this is a counselor who focuses on current situations to help clients understand their problems. So it's not going to be therapy for a long time. It probably is one-on-one, but it's a counselor, so they don't have as much training, so they aren't going to be as expensive. And it's not going to be like you wouldn't be going to this person for years. It would just be for that short-term situation. There's group therapy. So then this is several patients are guided by a therapist at one time to help each other cope with their problems. So now we have costs going down, right? Because there's more people in a room. Drug therapy. So this is treatment that can include tranquilizers, antidepressants, antipsychotics to relieve people's problems and help them cope with life. This is also going to depend on access to medical care and insurance. And then there's ECT, electroconvulsive therapy, also called electroshock therapy. This is when wires are attached to a patient's brain or patient's skull, and then they send low voltage electric shocks through the brain. ECT is absolutely not as common today, but it does still happen in parts of the US. Majority of the times it's used is for people that have patients that have bipolar patients with extreme depression. So being kind of in like a catatonic state of depression where they are not responding to anyone or any life around them. And it's going to be used if it's used as the last resort, ECT. It's also used for people, not necessarily just bipolar people, but individuals with depression that it's been resistant to other treatments. So again, as a last resort. And then it's used for some people that experience catatonic schizophrenia. And that's, I mentioned like people that aren't responding to any other therapy. So ECT can sometimes break people out of that catatonic state, but it's not used as often. Okay, that was a lot about ECT. Okay, social policies. So there are some major social policies that have been proposed. Some have been put into place, some are more widespread than others, but essentially we've got prepaid medical care, being paid to stay healthy, greater use of physician assistants and nurse practitioners, right, because they aren't as expensive to use as doctors, training more physicians because we have physician shortage, home healthcare, getting healthcare in the home instead of going to the hospital, preventative medicine, and then humanizing healthcare. I'm not going to talk about each of these. You can definitely read about them, but let's go into I think I'm just focusing on preventative medicine. So prevention, doing things before the onset of disease, it can be highly effective, right, in keeping people healthy. So one of the most preventable causes of death is smoking. Each year, about half a million Americans die from nicotine. So prevention would be to either never or to stop smoking. There are 3 types of preventative medicine, so kind of different levels of prevention: primary, secondary, and tertiary. It's just a fancy way to say third, right? First, second, third. Primary prevention keeps the disease from occurring in the first place. Secondary prevention is detecting a disease before it comes to the attention of physician. So I should give examples. So primary prevention would be things like getting a vaccination or making sure that you have the right diet and exercise to prevent a disease from ever occurring. Secondary prevention might be something like a self-exam to see if you have breast cancer, right? So that you could then go and get it taken care of if you needed to. And then tertiary prevention is preventing further damage from a disease that has been detected. So this might be someone who's been already diagnosed with diabetes, making sure that they're maintaining their insulin, or just in general, like controlling an infection. This tertiary prevention is often the same as just regular medical care, right? You get something, there's a disease that you have, and then you are making sure that you're treating it in a way that needs to be done so that it doesn't get worse. An example of preventative medicine, what is happening? We can focus on obesity. So today, about 62% of Americans are classified as overweight or obese. That classification is really based on BMI. And so this is what I want. What is happening? Your BMI is calculated, BMI stands for body mass index. And so BMI is calculated this way. And it's all these weird numbers because we have the American system of pounds, right, instead of kilograms and centimeters and inches. So you take your weight in pounds. So you can calculate your BMI right now if you don't know it. You take your weight in pounds, multiply it by 703, and then you divide it by whatever your height in inches is squared. So like if you're 5 feet, you wouldn't put in 5 squared. You want to convert that to inches and then square that. So whatever the answer is to that mathematical equation, you can categorize yourself in these categories of BMI. And so if it's less than 18.5, that person would be underweight. Then you can see 18.5 to 24.9 normal, overweight, obese, and then 30 plus obese, and then 40 plus extreme. And so 20% of deaths roughly are due to excess weight. And because of the numbers that we see in the US, researchers say that obesity is more of a danger to health outcomes than alcohol abuse. And it's not the BMI or the BMI category itself. It's what precipitates after it, right? So the excess weight leading, especially over time, right, leading to disease. So this could be things like diabetes and heart disease, and then that can be a contributing factor to higher mortality rates. Now, thinking about obesity and inequality, obesity is often framed as an isolated individual problem, right? Like some of these things I talked about earlier in class, like sexual harassment, a person experiencing sexual harassment in the workplace. So that's something you need to deal with, right? It's your own individual problem. Same with obesity. But there are several social factors that public health officials recognize that tend to cause obesity, right? Patterns that we can see. So people that live in food deserts versus not, we see higher rates of obesity in those areas. So this would be a food desert, right? That there's a whole long explanation on how we measure it, but to simplify it, let's say it's a neighborhood that has more liquor stores and fast food stores than grocery stores in it, right? So there's not as easy access for people to get healthy foods and non-processed foods, home-cooked foods, right? It's easier access or only access to things like fast food and then liquor stores or like corner stores, where you go in and there's like maybe some fruit on the counter and you're like, I don't know about that. That doesn't look as good as what you would see in like an HEB. Also, we know that there's limited healthy environmental opportunities in some places. So neighborhoods that have fewer parks or not as many walking and biking trails, either that are not there, they aren't well maintained, they aren't safe. Or run down sports facilities and neighborhood gyms, right? Some neighborhoods have these, and so it's easier, right, for people to go out and be active than it is for people in places that don't have them. We also, in general, have a declining necessity. to be physically active, because there's an increase in technology, right? So this is kind of the rise of the change in our economy. And like, I mean, I've been sitting for hours today, right? So I don't have to move as much for my job. Part of that has been helped along by technology, where we can order food. We don't have to go and get it, right? There's lots of things that technology has helped make life easier for us, but that also has decreased our need to be more physically active. And then there's limited access to, and also a high cost of physical fitness spaces, health food stores, etc. Right. So all of these factors are socially influenced and contribute to higher rates of obesity in certain neighborhoods compared to others. And so if you don't have the resources to mitigate some of those um, realities, right? You have limited access, or you can't afford. It's going to contribute to health problems over time that's related to this. So that's why we don't view obesity as an individualized problem, because if you just say it's an individual problem, then it's on that person to solve it. But if they live in a food desert, if they don't have access to X, Y, and Z to help with their health, right? They have a job, there's lots of reasons. If that's the situation, then it's not something that's you can just say is an individual problem and then it's on you, right? It should be more of this social realization of how are we as Americans living? What do people have differential access to, right? So there's lots of social influences too, inequality related to obesity. Okay, so this is just a recap of the things that I mentioned a while ago, really focusing on preventative medicine, but all of these other things are addressed. And so you need to make sure that you read those in the chapter, and we'll talk about this. Which do you think is best in class?